ultrasound in the pre-hospital setting. Is it all that it's cracked up to be? Is it something that's here today and gone tomorrow, or is it here to stay? Can you use it for other indications outside of just, say, maybe the traditional traumatic injuries? And have you ever heard of the rush exam? We're going to talk about all these things in today's episode of the podcast. I'm your host, Flight Medic Barry. Let's get this bird in the air, shall we? So let's go. Wheels up, 10-8 in service, visors down, safety checks complete, and we are off. We are airborne, ladies and gentlemen. Welcome aboard the flight deck. My name is Flight Medic Barry, as mentioned, and I'm so glad to have each and every one of you to join us today to talk about pre-hospital ultrasound. What do you think about it? Drop this in the comments. Does your agency use it? What do you think about it? What's your initial impressions on this thing? Because I'm excited about it. I think it's very promising because I'm a firm believer. And if you unleash the pre-hospital clinician to its fullest potential, man, do you have a weapon to really utilize and wield against some of these circumstances and problems and pathologies and things that we have to deal with in our patients. And of course, that comes with additional training and costs and all those other things that unfortunately is a whole nother podcast for a whole nother day. But I really believe that if all that got pushed aside and, if a girl could dream, right, you could actually really utilize harness the power of the gods, right, and utilize a paramedic and the pre-hospital providers to their maximum potential and really do some damage out there. But right now we're, of course, just really trying to figure ourselves out and a lot of things holding us back. But there is hope because this is kind of the pre-hospital ultrasound is something that's kind of peeking out of the void saying, hey, right. And we're seeing some of these things showing their face and showing their proof of concept, showing their relevancy in the field to a point where it's almost so profound, it's undeniable. And we're going to talk about the data because the data is just wow. That you just can't overlook it. You can't, then it's just pretty obvious. We're stuck clinging to old, antiquated, obsolete protocols. The whole, remember, just give fluids and turn it into Kool-Aid concept. Well, we're really done with that nonsense. And I think that we're making a large shift. It's just taking some time because right now only 4% of our agencies, both Canada and United States combined, so 4% for both of them, is utilizing this diagnostic tool. So what in the heck is this pre-hospital ultrasound? From a primitive sense, right? Like we know what an ultrasound is. I think most of us do if we're, and if you're maybe just, somebody who's not in the medical field watching, right? Ultrasound is using sound waves to be able to bounce sound back to gain an image, right? So we can use pre-hospital ultrasound in obvious ways, right? And say, looking for cardiac motility during an arrest. So when somebody's heart is stopped, we are looking for cardiac motility, something to give us like, if we're really like, how's that fine VFib? Is that, what's going, is that really PA, right? That can be a potential justification to use it. What they found was that one study identified of an absence of cardiac rhythm using Pocus in the pre-hospital setting has a 97.5% positive predictive value for death prior to leaving the ED. This shows that the Pocus has great potential to guide decision-making regarding pre-hospital termination of care. It gives us an extra layer of justification of saying we did everything we could. We've checked this box, and done this much of CPR and rounds of epi and all of that stuff. And on top of that, we have an ultrasound that says ABC. And that's just kind of like that icing on the top to really say, look, everything is pointing to this is a termination of efforts sort of situation. Something that I found very interesting. How good are you at your pulse checks, ladies and gentlemen? If any one of you says, I'm the best, well, you need to be humbled a little bit and feed you a slice of humble pie because it shows the contrary, right? And I would love to say that I'm like the great at checking for pulses, but maybe how many do you don't know you missed it if you don't feel it, but it's there, right? Like, so what I mean by that is one study found a median time of needed to perform a manual pulse check was 24 seconds. What does the AHA, ACLS say? the ACLS guidelines suggest 10 seconds, no more, to find a pulse. Well, the evidence is suggesting that for every 5 seconds to increase of that pulse check time, mortality increases by 18%. So we got a problem on our hands. 24 seconds to find a pulse. Well, okay, how do we fix that? Because further on, I will submit, in addition to, furthermore, 45% of patients in the study who did not have a carotid pulse had a blood pressure of 80 or higher. Whoa, mic drop there. Like, that kind of opens our eyes. Maybe we aren't as good at checking our pulse, or maybe there's things going on. So how do we fix for that margin for error there? Well, Pocus. Pocus was found to have a higher first attempt success rate of identifying a pulse over a manual pulse check. So it's in the cardiac arrest, ACLS, all that stuff. It's showing its benefit of maybe like, hey, I don't feel a pulse, and you can utilize that as maybe a more accurate way to determine whether or not you have a pulse or not. Also, reversible causes of cardiac arrest. So our systole and PEA associated causes, we think of our H's and T's, remember, hyper K, hydrogen ion, thrombus, tension pneumo, and tamponade, and so on. Well, because we know that those are reversible causes, or things that can, at least they have an intervention associated with them that could turn the tides of the situation. But, how many of you out there don't really have, because we don't have ultrasound, we have to just kind of, just bilateral chest starts just because maybe it might be, and we're just doing things blind. Well, instituting something called the EFAST exam, we're able to deploy this really quick technique that demonstrated that providers were able to do it no problem. So the FAST protocol may be used to detect pneumos and retroperitoneal bleeding and all sorts of different things, cardiac motility and such. And they found that pre-hospital providers were able to perform this no problem. And you're going to be really impressed with the statistics that they go on even further. When you're looking at traumatic shock specifically related to the abdomen, they noticed in abdominal trauma, its sensitivity and specificity in hospital for getting the problem right was 100 to 97.5% done in hospital. Check this out. Us Neanderthal, knuckle dragging, crown eating first responders out there, 90 to 99% pre-hospital accuracy and specificity and sensitivity. So we're not doing too shabby, So I think that that's really something to really pin on the wall. There is that we're not below or beneath being able to utilize this effectively for the right reasons and get the right answer. Because the argument can be made, well, you guys, just wouldn't know how to use it or whatever, those kinds of potential excuses. Well, again, back to my earlier statement in the beginning, adequate training, really that'll, I think, diminish any of those, a lot of those, mitigation of a lot of those risks there. So in addition, right, really cool, aortic aneurysms. Check this out. This statistic will blow your mind. Or maybe not. So the specificity in the ED and the sensitivity. So they're getting it right 100 to 98% of the time using, so, obviously they're, good at detecting with the ultrasound, of course. But what about paramedics? What are we doing? A trained ambulance paramedic, underscore trained, right, performed this exam on the abdominal aorta in 20 symptomatic patients, and blinded experts who judged them agreed 100% were right. Of course, 20 is a small patient subset, but it's starting to, right? We already saw in abdominal injuries, and now we're seeing aortic aneurysm. So we're building a stronger case that we have a right, or we have the right to be in the conversation, I'll just say, to use this diagnostic tool in the field with accuracy and precision for the right reasons, we're just building this case out even more for why we need, or why we're kind of diminishing or breaking down some of the narratives that might explain why we don't need it or whatnot. Because, have you seen some of the guys we worked with and stuff? Well, of course, there's maybe underperforming individuals everywhere, but there's also one heck of a group, majority, I should say, who are just phenomenal, and they're just craving and waiting to get the training and want to be better at providing more for their patients and ultimately translate in better morbidity and mortality and out of hospital, 30-day evaluations and that such, right? So as promised, a rush exam. What in the heck is that? Well, the rush exam is actually just a fast exam on steroids. See the fast, right? We're going to do the lung slides. We're going to look on the right upper abdominal quadrant area, kind of Morson's pouch, looking for the retroperitoneal bleeding and such. And we're looking on the left for the splenic and the cardiac window. But what we can now utilize it for is the rush exam is also known as the rapid ultrasound for shock and hypotension, kind of looking for atraumatic causes. So now we can incorporate some techniques to look in our atraumatic patients. So when we're looking maybe at the heart, we can see specifically when we're looking at a parasternal long axis view or plaques and apical 4-chamber view. So really what that means is when you're posturing the probe correctly, you're going to see 4 chambers of the heart in nice dividers. So you'll see left atrium, right atrium, ventricle, right, and you'll see it in a nice 4-quadrant window. And, these allow us to see whether we got good squeeze, which would be suggestive, or bad squeeze, good or bad squeeze, which could be suggestive, proving in and out of cardiogenic shock, while a hyperdynamic left ventricle would be suggestive of a hypovolemic or distributive shock. So we can start seeing, by looking at the behavior of the myocardium, we can start maybe going, oh, okay, right? We might start formulating a stronger suspicion for what we may already be thinking. It is important to remember, though, that both pulmonary embolism and tamponade also frequently present with a hyperdynamic left ventricle. So there is kind of overlap, but nonetheless, it may get us closer to where what we're trying to accomplish. So the IVC, or the inferior vena cava, in the rush exam can be allowing us the ability to see if we have an engorged IVC, which would then mean we could have obstructive shock, we could have volume overload. But what if we have a maybe collapsing IVC? They may be hypovolemic, and that could be an indicative of some fluid responsiveness. So now, instead of just kind of like firing and forgetting, we're starting to get some diagnostic data to justify what we're doing, right? So now it's not just this kind of very primitive game we're playing, but instead it's now actually, critical thinking and using multiple different diagnostics and history and assessment findings and all of that to come together and start adding being more precise, more accurate. We've already seen in the hands of the right provider, as far as training goes, we're near close to as accurate as the ED. So being, extensions of the ED in a way, adding that to the arsenal is, just a no-brainer, right? Similar to the EFAST, the final view of the rush exam involves the lungs. The rush exam can use the same ultrasound views as the EFAST, which the EFAST is what we talked about, the lung slides and all of that. That's used really quickly, and it's been shown that paramedics can do it very well, and they can do it quickly, and it also does not compromise further interventions and life-saving maneuvers, right? So they're showing that we're not going, hey, let's just do an ultrasound while we just, not do compressions, right? So normal lung views, when shimmering at the pleura with respiration, or known as the beach sign, and you can't miss it. You'll see it. It looks like it's so cool. Or on the M mode, while a pneumothorax would present with a barcode sign with M mode, right? That's like motion mode, right? So, and I don't want to inundate you with a bunch of not nonsense, but just a bunch of information all at once. But this is just to draw the case that this is something that I really think is here to stay. And I think it can be the implications and the applicability for it in the pre-hospital setting is just becoming endless. So, okay, what's the data say on this rush thing, right? So an early rush exam in the ED can help quickly identify etiologies in a non-traumatic shock patient. But here's the real cool data. The physicians who were able to identify the correct diagnosis by deploying the rush exam within 15 minutes or less got it right 80% of the time. But if they waited, then that number dropped to 50. So kind of hinting at early deployment of the ultrasound can be key to getting that diagnosis right, deploying the appropriate interventions, and really giving that patient the best possible chance of decreased mortality, morbidity, and decreased stay at the hospital, and of course, all the other complications that come. So I just submit to you this is that the ultrasound, I believe, is here to stay. And I think that more agencies are going to jump on board. I know there's a cost associated with it. There's a whole lot of other things that are going to hold this whole thing back from everybody getting on board with it. But I just see its applicability in pre-hospital is just vast, right? We've already talked about its use in cardiac arrest. It's used to help fine-tune our search area for our reversible causes of PEA and asystole and fine-tune our H's and T's. It's helped us determine fluid responsiveness, strain on the heart, potentially decreased or changes in cardiac motility, which all can start help painting a picture that can further determine accurate definitive care, accurate interventions at a more swifter time. I think that that's all good things. And of course, if you're going to be well-rounded and try to be as objective as possible, of course, the cons of this is it can be something that can delay certain things if not put in the appropriate time, time and a place, and also in the hands of a educated, trained professional clinician is going to make all the difference in the world. If given to just anybody and said, here you go, the numbers and the statistics and data of accurately getting things right is going to go down. And then it draws the argument that, we don't need, kind of like the argument with intubations, in the sense that first pass success for pre-hospital was very, very low until the video laryngoscope came into play and at least kind of justified keeping it around in the pre-hospital setting with increased first pass success. So with that being said, kind of in conclusion, the pre-hospital ultrasound is, I think, here to stay. I think here to really just drop it on the table and say, here I am. It's got so many applicable and traumatic and applications, and traumatic and non-traumatic. And I'm really excited to see more agencies use it. I think it's going to gives you a lot more information that's going to then just spiderweb us out into more training opportunities, because then we're going to learn a lot more about ultrasound, which then tells us we get to learn more about the conditions that these patients are dealing with. And I think all of these things are good things, increasing time to definitive care, increasing to the time to definitive treatment, and decreasing mortality and morbidity. So with that being said, ladies and gentlemen, I will put this aircraft on the ground, and we're going to go 10-7 out of service. Visors up. See y'all.